record and we're ready to roll. So with that in mind, I want to thank everybody for joining us today. I'm going to turn it over to Joe so he can introduce himself and get started with the webinar.
Sure. Let me just share my screen here, make sure that's up. There it is. Okay, very good. Can everybody see that?
Perfect.
Yeah, very good. Okay. Okay, so good afternoon, everybody. My name is Joe Safdieh, and I'm the Associate Dean for Curricular Affairs at Weill Cornell Medicine in New York City. I'm also Vice Chair for Education and Professor in the Department of Neurology, where I maintain a clinical practice in general neurology and headache medicine. It's an honor to speak today to the ACE group, and I have some experience collaborating with ACE in the past on their publications committee. We worked on a paper a number of years ago now, looking at the crisis for recruiting community preceptors, and also helped to write a chapter for the guidebook for clerkship directors. And actually, this talk is based on that chapter. And I just heard that we might be going into a new edition of the book, which is great. It's a very useful book. I was a clerkship director for about 15 years or so, and that book was extremely valuable. So I have no disclosures other than I received an editorial stipend from the AAN for being editor-in-chief of Neurology Today. And I see Mona joining. Hi, Mona. So here are the basic learning objectives. And like I said earlier, I tried to adapt this talk to really follow the flow of the chapter that I put together for the ACE Clerkship Director Guidebook, so that any of you who would like to look at that chapter can kind of use this talk as a way to maybe frame it. So we want to make sure, number one, that we're able to define the term clinician educator. Presumably, some of you are clinician educators or are aspiring. The second is to make sure we understand what the roles are of a clinician educator. I want to describe the process of starting a career as a clinician educator if you're a more junior person. And then, of course, if you already launched into your career, demonstrate the steps required to achieve success in this role. And so it's important that as we think through this, because I want to try to make this talk practical and valuable, I'm also going to try to think more generally about career advice, making sure that it's important that you always keep in mind what you want to do, what tools you'll need, what assistance you'll need along the way, and how to navigate the promotions ladder is something else I'm going to talk about as we kind of work through this talk today. It's a relatively small group, which is good. I know more people are going to join this time of day. People, like I said, probably get their lunch and then turn on their Zoom. But feel free to ask any questions. You could use the raise hand feature if you have one. We can save them for the end probably. But if you do have something that's, you're itching to kind of get out, feel free to raise your hand and I'll call on you. So it's important to know what you want to do, right? This is your career. Okay, so ultimately, right, as you go through medical training, right, you're in medical school, you're in residency, you're in fellowship, and pretty much somebody tells you where to be every day and what time of day to be there, and you just kind of follow along with the schedule that was given to you. But then you step past your training, and now you have your first job, and of course, you're going to be told you might have to see this number of patients, or you might have to, contribute to this part of the department. But ultimately, you have to define for yourself in academic medicine what the centering of your career is going to be, right? So it's important early on to ask yourself, what is my vision? What do I really want to achieve? Not only what do I want to do, but how do I want to show that I did it, right? So it's important that you set your own goals and that you choose an area of excellence for sure. One of the things that I hear from people who are frustrated when they're not succeeding necessarily at growing in the academic department is not that they don't have things to do. They're doing this, they're doing that, they have this long list of things that they're doing, but they don't really have any kind of strategic approach to where they're actually going, right? So they're doing this, they're doing that, they're doing this, and they feel like I'm doing so many things, but I don't really have anything to show for it. And what I'll remind them of is it's important before you start doing things to understand, right, where you're actually planning on going, because there are so many different paths in front of us in an academic career, and you could be doing a lot of things, but if it's not actually leading you to a direction that you actually set out, then you may end up getting lost and doing a lot of things and not having much to show for it. So, of course, in any academic department, there's going to be at least three missions that have to be balanced, right? There's patient care, there's research, and education. And I want to emphasize today, and I know I'm speaking to educators like myself, that all of these are equally important. And I think in some institutions, perhaps the education mission gets a little less attention. Frankly, it doesn't necessarily bring in revenue, right? Like patient care certainly can, and research to some extent can. It may not bring in a lot of publications or grants like research certainly can. But if you have an institution or a department where education is really not emphasized and not attended to, then ultimately you're going to have an unbalanced department and you're not really going to be meeting all of the things that the department needs to meet. So as you kind of start a job in academic medicine, it's important to ask yourself, which of these domains do I really want to focus on? Recognizing that it's highly unusual that any one person is going to do only one of these things, but it's good to have a general understanding of what you're looking at. Now, one of the things that we think about is, why should we teach at all, right? I mean, there's a lot of things you could do in an academic medical center, but I'll argue that teaching is very gratifying. It forces the educator to stay current, right? One of the reasons we like to teach is that actually when we work with junior learners who are asking us questions, we want to make sure that we're staying abreast and ahead of actually what the trends are. So it actually forces us to stay current. And I'm going to demonstrate today, hopefully, or try to, that it can actually promote a successful academic career. Historically speaking, people were often put into teaching roles when they lost their grant, right? And the chair was like, well, what are they going to do right now? I guess I'll put them in a teaching role. But I would argue that nowadays, really, we're in a much different place where people actually are entering these careers and are using it as a way to actually grow, not as a landing spot when they're kind of done, okay? And I'm a neurologist, so I'm not going to spend a lot of time talking about neurology, but I'm going to do some examples of neurology. Some of you may have heard the term neurophobia, which is the fear of neurology and neurosciences that leads to a paralysis of thought or action. And as an example in my field, right, many people go into the field because they want to specifically show students that actually that's something that doesn't have to be the case if it's taught correctly. Okay, and actually, I'm just going to give this show what I mean by that, because in my field of neurology, what we see, for example, is that people are really interested in it. Okay, if you look at a level of interest, it's kind of here. This is a survey that was done from the UK. And in the UK, neurology is actually one of the many fields of medicine. It's not a separate residency, it's a fellowship. When they survey people, what they find, and these people are actually physicians who have trained in medicine, that they report that they know the least about neurology. They report that it's the most difficult. They report that they have the least confidence in it, but they're interested in it, right? And that creates a cognitive dissonance, because if you think something is hard and you think you don't know it and you don't feel confident in it, but you know it's important, that's going to make you scared of it, right? And so what I tell people in my field who are interested in education is that we can fix this. We can fix this because when we actually, when the survey, which is old, when they actually followed up on the survey and they asked people, well, what about it makes it so hard? They said they were taught it poorly, right? So poor teaching is really what it comes down to. It's not that there's so many diseases. It's not that there's complex anatomy. It's not that there's too many medications. It's that they were taught it poorly in the first place. Okay, so teaching is really the key. And ultimately, whether or not you're going to be caring for patients in your career, if you're improving how people care for patients, then you're actually making a very big difference. So going back to the slide I showed a minute ago, right, we have these different roles. And like I said earlier, it's unusual that any one person in an academic medical center would only contribute to one mission. It's certainly possible, right? You could have the voluntary faculty member who is seeing patients full time, but they probably have a student occasionally coming into their office. So they're not 100% patient care, but they might be close to it, right? You might have the person who has a bench lab, multiple grants, and is doing basic science research, but they probably have a PhD or an MD PhD student in their lab, and they're doing some teaching, and perhaps they're going into clinic or service once in a blue moon, right? And then you might have the professional education dean, right? The person who really is only involved in education administration, and every medical school might have somebody like that. But most of us who are involved in education as our primary missions, right, are still doing either some patient care or perhaps doing education scholarship, or maybe even have a small clinical research program, right? The nice thing about being in an academic medical center is that even though you can have an area that you really want to demonstrate as your area of interest and excellence, and I strongly encourage everybody to do that, it doesn't mean you can't dabble in the other missions. And that's, I think, part of what makes it really, really unique to work in an academic medical center, okay? But it is very important to ask yourself, of these three, which is the core of my identity? Because ultimately, when you're going for promotion, okay, you're going to be, people outside of the institution are going to be asked, what is this person known for? Okay, and if you're thinking that you're going to go up, for example, on an education track, but you're known for your care for patients, or vice versa, then you're going to run into a wall. Okay, so it's important that you understand that concept. Now, This is a very important, very, very important slide because ultimately this is, I think, where a lot of people go wrong when they're trying to get promoted as a clinician educator. There are actually four distinct tasks. There's some overlap, but there are four distinct tasks that really make up the job description of a clinician educator. And of course, the most important one is being a really good teacher. I would argue that you can't do any of these things in education if you're not a really good teacher. The problem is that's not enough. Okay, we have people who are really wonderful teachers who give great lectures, who precept students in small groups and PBLs, right? They attend on the wards and they're acknowledged by students with great teaching feedback evaluations. They may even get an occasional teaching award. And after 6, 7, 8, 9 years, right, when they go for promotion, they may be disappointed that they don't really get considered. And the challenge here is that being a great teacher, it's critically important for these roles, but it's not in and of itself necessarily going to be enough. Because in some institutions, they're going to say, don't show me what you did, okay? Don't show me what you're doing, show me the outcomes, right? And the problem is when you're teaching, you might have things like teaching evaluations and maybe some teaching awards, but it's not necessarily enough. You also have to think about the other roles that you can think about as part of the clinician educator career path. And that includes curriculum development. And I would argue that if you're teaching a lot, you're likely going to want to do curriculum development because you're going to ask yourself, well, what am I teaching? Am I just teaching what other people are telling me to teach? Or do I really enjoy teaching and I want to help develop my own materials, especially if what you're teaching is not necessarily what you think is the best way to do it, right? You might want to think about a new way to teach or develop around the new topic. If you're really good at teaching, you may want to ask yourself, do I want to get involved more in education programming? Do I want to develop leadership roles, right? And this is not something that comes immediately, but it's something that over the course of one's career, and even early on, an assistant clerkship director, an associate program director, right? Maybe a small fellowship director. These are the kinds of things that are important to do. And then, of course, education scholarship, which I would argue 10 years ago, maybe you can get by without any of. But today, you probably need to do some education scholarship. And some people actually focus on this as the primary point in their career as a clinician educator. We have some people in my institution who actually used to be teachers and course administrators, but now they really focus their whole career on studying the outcomes of educational systems. And this is the main focus of their career. Okay, but ultimately, they're going to start here, right? It's highly unusual that somebody's going to go into education administrator roles, curriculum developer roles, or education scholar roles if they didn't start as a great clinical teacher. Now, clinician educator, clinician is still the first word. And I think that in my field of neurology, when you look at the data, right, when we look at our residency program directors and neurology clerkship directors, which I think are two of the prototypical, clinician educator duties, at least in my field, okay, what you see is actually while they're spending a lot of time teaching, they're spending most of their time in a week seeing patients, right? So when this is the national survey of all neurology program directors in the country, and in a typical week, they're seeing, they have 23 hours of patient care, okay? And they get about 43% of their effort protected, okay? And now and actually this is in 2007, now it's 25% for clinical duties, 6% for teaching, 13% for administration. So even though these are the top level resident administrator role in the department, they're still spending more than half the time actually seeing patients, or almost half the time seeing patients. And in the clerkship director, right, when you look, and Mona's familiar with this very well, when you go from 2005 to 2017, things certainly got a lot better, but still, there's only 1% of neurology clerkship directors in the country as of 2017 who have more than half their time protected for their clerkship role. And that's probably okay. I don't think you need more than half your time for the clerkship role. 31% have about 0.26 to 0.5, and 43% have about 0.16 to 0.25. And of course, that doesn't mean they're seeing patients with the rest of their time. They could be doing research or other things, but for the most of them, they're seeing patients for the other time, right? So the point I'm making here is that all because you're seeing a lot of patients doesn't mean you can't be a clinician educator, but you do have to ensure that as you set up your initial negotiation with your chair, that this is accounted for. And I'm going to talk about that in a few minutes. Now, the good news is everybody, every department needs teachers, right? So whether a chair of a department in an academic medical center cares about teaching or not, they still need teachers, right? They're still going to need somebody to run a clerkship. They're still going to need somebody to run the residency. They're still going to need somebody to run fellowships, right? They're still going to need somebody to liaison with the first or second year basic science course and whatever topic that department kind of aligns with, right? They're going to need somebody to help with grand rounds. They're going to have CME programming, right? The medical school is going to be calling them saying, I need somebody for this professionalism committee. I need somebody for this, teacher learner committee. I need somebody for this curriculum committee, right? The hospital is going to be calling and saying, I need somebody for this, quality education, quality assurance committee, a GME committee, whatever it may be. So the chair is still going to need people in the department who are interested in education. Okay, so that's kind of important to remember because ultimately there are these roles, and some of these are formally funded roles, others are more unfunded service roles that may grow into those funded roles. So it's important as you start your career, right? Let's say you're starting your career and your goal is to be a residency program director, or your goal is to be a neurology clerkship director, or your role is to become an education dean. Okay, it's good to know that, right? But you also want to make sure that you're versatile because if you come into your chair's office and you say, listen, I'm here, I'm so excited to start this job, and my goal is to become the clerkship director, and I'd like that within 5 years, and that's all I'm going to be focusing on, and that's what I'm going to be doing, and I'm going to be doing a great job teaching and a great job developing curricula, and I'm going to do a needs assessment, and I'm going to give great lectures, and I'm going to do my best to really excel in that area, okay? And the chair says, that sounds really, really great, but I'm also starting this new clinical program in your specialty, and I'd like you to help with developing some of the quality measures and this and that. Okay, and your answer shouldn't be, well, I know that you want me to do that, but unfortunately that's not interesting to me, and therefore I'm not going to do it. Right? That's not really an appropriate answer. You have to negotiate, as we'll see in a minute. Communication is always bi-directional. So it's important to know what you want. It's important to push yourself in that direction and to do what you need to do to get there. But at the same time, okay, be versatile and recognize that it's not only about you, right? You also have to ensure that you're helping your chair meet the needs of the department, okay? So you don't always have to say yes, but it certainly depends on who's asking you, right? I think that's important to remember. Now, you want to know what tools you're going to need in order to succeed, right? You're certainly going to need communication skills, and that's something I just referred to a minute ago, and we'll talk about that a little bit more. You're going to need to be organized, okay? You're going to need to be organized. One of the things that drives us crazy when we meet with junior faculty when they're going up for promotion or they're having their annual review is when they don't actually have listed in one place all the things that they're doing, right? Their CV is disorganized, their educator portfolio is non-existent, everything's on sticky notes that they're pulling together, right? It's important that you're organized and that you are at least every few months or at least twice a year, okay, keeping your updating your CV, updating your educator portfolio, pulling together different talks that you're asked to give. You don't want to have things be all over the place. And it's also important that you have long-term vision. And this is a critical point that I kind of talked a little bit about earlier, but I'm going to stress a little bit more now. It's really important that whoever is responsible for your professional development, typically that's your chair, is aware of what you want for your career. I had a meeting a few weeks ago with a junior faculty member in a different department who was upset and said, there was this course director position open, and I'm frustrated because this other person got asked to do it, and nobody asked me. And I think I could have done a great job. And my response was, well, did you knew it was open? Did you ask? No, I didn't ask because wouldn't they know that I'd be interested? I've always said I'm interested in education. I said, yeah, but you should have asked, right? You should always, go put yourself out there, right? Make it known what you want. But also, if you see an opportunity, don't necessarily expect the person to ask you. And it may not be that it was done on purpose. It could have just been an oversight. The chair was busy and said, oh, this person could do it. I'll nominate them. And now you feel kind of scorned. And actually, I know in my role that person that was appointed wasn't really thrilled about doing it, but now is going to do it. And there was somebody in the department who actually would wanted to do it, but never said anything. So it's important that everybody kind of is open with each other, right? So it's important from before day one. It's important that there's an alignment of goals. If you join a faculty and you're told your expectation is X, Y, Z, but you want to do ABC, then it's not going to work, right? It's important that you and the chair or division chief, whoever is hiring you, have a shared vision for what your goal is, because they want you to succeed, but they also want the department to succeed, and you want to find that happy space where everybody kind of is moving in the right direction. You want to refine these things on an annual basis. Okay, and it's very important to kind of do that. Some chairs are better than others. This is an LCME requirement, of course. There's a faculty development requirement from the LCME that on a regular basis, the faculty review their annual goals with the chair and they refine them. However, we recognize that there's a difference between a check the box requirement and an actual requirement, right? It's like when students tell us that they didn't get mid-clerkship feedback, even though we know they did. And that's because even though they did, it wasn't really useful for them, right? So I think that, we can check the box, but ultimately it's the chair or division chief's responsibility to really provide critical feedback and review their understanding of what you're looking for your career and where you actually are. So it's very, very important to have a plan, and it's very important to ensure that you're following your plan, recognizing that along the way you may have to make a few adjustments. So your chair should know from day one that you want to be a clinician educator if you're starting your first job. And if your chair is not supportive of that, then maybe you need to look for a different different job, right? I mean, if your stated career goal is to become a neurology clerkship director, and you're interviewing with somebody for a position, and you say, "I'm interested in being a clerkship director," and their response is, "Oh, really? That's not that's something we give to the senior guy or the senior person who's ready to retire. Nobody really wants to do that." Well, then that might give you a sense that this person doesn't value the role of education, and you might want to think about not working there, right? So it's important that there's mutual understanding, there's a support in the goal, and that they're willing to provide you some protected time to teach, right? There should be some understanding that there's a little bit of protected time. There isn't going to be much in the beginning. I can guarantee you that. It may be very little, but ultimately there should be some sense. For example, if you're going to, let's say, devote time to curriculum development, right? If you're joining a department and you're considering, for example, a project where you're going to be building a new curriculum for a certain disease topic that is an identified need to do, okay? Well, it's hard to do something if nobody understands that that's actually something that you're supposed to be doing, right? If you're spending time doing it, but actually you're supposed to spend that time seeing patients, then you're going to end up being disappointed when you're called into the office to say, well, what's going on, right? We're paying you 1.0 to be a clinician, but you're only doing 0.8 work, right? So it's important that there is actually some sort of understanding of that. Early on, ask to teach in a basic science course with the clerkship. Ask about any potential leadership roles, maybe as an associate course director. Be humble, okay? Be humble. I don't. We've had people come out of fellowship and interview and say, "Oh, my career goal is to become the chair of a department." Okay, that's okay, but you want to be careful about how you frame that, okay? Because that could sound a little pretentious, So something along the lines of, I really want to get involved in education. I really enjoy developing programs for the next generation. It's something that I really get excited about and I'm passionate about. And I'd love to see where that leads me. One day I could see myself being a clerkship director. One day I could see myself being a program director. I recognize there's many steps along the way, but I'm willing to do that work. That's a better way to kind of frame it rather than I want to be the program director. When can that happen? Okay. Because you want to talk about the steps along the way. It's really important that you make your chair know to call you, like I said earlier, when an opportunity arises. Otherwise, you might be disappointed when you're, quote, passed over, not because of any malicious concern or reason, but just because the person forgot or didn't know that you were interested because you never said anything. You have to make it clear, and you have to reiterate that. Now, can you even start a residency, right? I don't know how many of you are involved in GME programming. Some of you presumably are, but you may be familiar with the fact that there are now tracks in residency programs around the country in all specialties that help residents develop the skills towards clinician educator career development. And this is important because while all of our residents have to be teachers, of course, and in fact, the ACGME has resident as teacher as a requirement, this is more than that, right? This is not just teaching them how to write feedback, and how to teach at the bedside. All residents should get that. This is really teaching them how to navigate the career path of a clinician educator, how to develop curricula, right? How to get involved in education leadership, how to do education scholarship. So we started our track in 2019 in our neurology department in New York City, and we have 2 to 3 residents a year on the track. And we have a formal application process, so it's not something that residents specifically match into. They match into our standard categorical residency. We have 9 residents per year, and in their PGY 1 year, they apply to the track, and they apply to the track by writing a statement of interest and putting together an educator portfolio, which of course for some of them is very, very thin, but that's okay. It's a good exercise for them. And then they apply, and then our departmental education committee will select 2 or 3. And if they're selected to the track, they get mentorship from a member of the education committee. They get opportunities to do direct teaching in the neuroscience course, the neurology clerkship, or the neurology sub-internship. They get an opportunity to either develop curricula or to do education scholarship. And frankly, typically that's both, because typically the curriculum serves as the basis for the education scholarship project they're going to be doing. And we actually presented on this at the American Academy of Neurology meeting about 4 years ago. And like I said, they're involved in these different color-coded areas: teaching, curriculum development, education leadership, skills development, and scholarship. We do it in a graduated way. So as they go from PGY1 to PGY4, and every year they get a little bit more of advanced things to do. By the end, they're expected to present or publish a scholarly project in neurology education, which is mentored. But that's not the only part of it. They're also doing teaching. They're helping to coordinate some of our departmental activities, and they're also getting faculty or resident education skills development. And then the last thing I'll show on this is just an example, because this sounds a little vague when I try to explain it. It's always best to actually show concrete examples. So these are some of the projects that our residents have worked on. Our first resident graduated 2 years ago, actually, Sarah Peruta. Now she's an attending neurologist at Westchester Medical Center, and she did a project where she looked at the impact of neurology morning report on neurophobia, and actually this was presented as a poster at a meeting. And then Moises Dominguez, who's now a faculty member with us, and Angeli Song, who's one of the current residents, developed this beautiful video-based primer for neurology consults for non-neurologists who rotate with us, with a pre and a post test to see if it improves their knowledge and confidence, because people come to the neurology service when they're from internal medicine or psychiatry. They're often scared, and we're trying to kind of relieve that. Aaron is an artist, and so he developed these beautiful visual teaching tools for advanced practice providers in the neuro ICU. His art was used actually as part of a study that was done in our neuro ICU, which was published in the Neurocritical Care Journal. Text messaging is a teaching tool. Aaron Zelikovich is a resident of ours who's very involved in the neuro Twitter community. He developed these training modules. So this was published in Neurology Education. We have residents doing they're developing curricula. So we have one on how to call a consult for all the second-year medical students that Andrew did. Incorporation of social determinants of health into all of our neuro PBL cases that Safdieh and Nathan did. They also developed a brand new PBL case, because the old PBL case was really outdated on chronic pain. There's flipped classroom sessions on myasthenia gravis, and then the newest ones, Kara and Evan, are developing a pharmacology guide for Parkinson's disease for the second-year medical students in the neuroscience course. And again, all of these eventually are going to have some sort of scholarship associated with them. They're all part of different IRBs. So this is something that we're very excited about, and it's really enhancing the culture of our department by allowing our residents to get involved not only in basic and clinical research, which historically they've done tons of, but really getting involved in education, scholarship, and curriculum development if they were so interested. Now, people ask, do I have to do a fellowship in medical education? These things are out there, they exist. And I would argue that for the most part, not really. Who benefits from more advanced training in education? There might be some people who do, especially a master's degree in education. Who would benefit from this? Well, obviously, you don't need one to succeed as a clinician educator, because if you look at most of your institutions and you look around, successful clinician educators, including clerkship directors, program directors, education deans, most of them don't have an advanced degree in education, right? So you don't need one to get to these places. But here's where it's valuable, in my opinion. It's valuable if you really want to focus your career on methodologies in education research. If you really want to be a bona fide education research scholar, and that's what you want the core of your career to be, okay, then it might be helpful, because ultimately you don't learn in medical school or residency advanced biostatistical models, right? Novel ways to think about developing outcome measures. So people that I know that have done masters in education, they're the ones we turn to when we're trying to figure out, how should I structure this education research study? What outcome measure makes the most sense? Does this survey make sense, right? These are the people that really have that advanced knowledge. And as part of their master's degree, they often get to, of course, do a project for their thesis, which helps them also advance their career. So that's where I think it's valuable. But I would argue that you don't need it, because I've had residents of mine even ask me, like, if I want to be a clerkship director, do I have to take a year and do this? The answer is you don't have to. But if you want to really, really get deep into education scholarship, then you might want to consider it. But it's not necessary. I also would argue you don't really take a year off to do these things. Many institutions, I was just talking to somebody recently at Yale, they actually allow you to take a third of your time over 2 years as a junior faculty member to get a master's degree in education if you think that will be valuable for you. So there are ways to do it and build it into your job. Setting up a clinic, for those of us who are clinicians, like I said earlier, clinician educator, the first word is clinician. You can't skip this step, and nor should you ever think that that makes sense. Okay. I'm a curriculum dean. I meet a lot with people who want to be course directors or unit leaders or clerkship directors. In fact, I interview anybody who's going to go into one of those roles because only the curriculum office can appoint them. And here's the one thing that they're going to tell me that's going to end the interview early. And by the way, you'd be surprised people say this. The one thing they're going to tell me is when I ask them, so why do you want to be a clerkship director? It's a very easy question, right? I mean, it's not a trick question. And if their answer is, well, getting tired of seeing so many patients, this protects 25% of my time, and I'll get to kind of, have a little less patient care time. I mean, I'll keep the interview going because I'm polite, but that's going to basically be an immediate no, right? I'm not going to hire them for that reason. That's not a reason to do a job. You shouldn't want to do a job to do less of another job you don't like, okay? The answer should be that I really want to do this job because I can't wait to work with students. I'm so excited. I've been working with them in different settings. I can't wait to kind of oversee this program, hear all these great ideas I have. As part of that, I know I'm going to end up seeing less patients. I'm comfortable with that, but I also love seeing patients and I want to continue seeing as many as I can, okay? You have to be good at seeing patients. Ultimately, if you're not a good clinician, you're not going to be a good clinician educator. And I'm going to show you in a minute some data to support that, okay? We all know when we were medical students, when we got a lecture from somebody who hadn't seen a patient in 20 years, right? That was very apparent right away, okay? You have to be able to speak about patients that you're seeing and use them as examples, right? Students immediately perk up when you say, just last week I saw a 25-year-old guy who had this, and immediately they perk up. For the last 20 minutes, half of them were sleeping. The minute you bring in a patient, the minute you say a vignette, they perk up, okay? Because you're telling a story, and people love hearing stories. Okay. Being an enthusiastic teacher is important, and getting yourself known in the local community region can be very helpful. I can't understate this enough. It's really, really important. You want to make sure that you're not just teaching within the walls of your institution. Doesn't mean you have to give lectures globally, nationally. You don't have to get invited to the Mayo Clinic. You can teach, nurses. You can teach the public. You can go to the public library in your local area if they have a lecture series and, health topics and give a lecture there. But it's important to do this because even for your first promotion, they're going to look and see, how do we know this person is acknowledged as an expert in their area outside the four walls of the institution? And it doesn't have to be, like I said, very fancy, but make sure that it's something outside of your institution that's going to help you get a little closer to the goal. Right. Getting settled, right? Getting more involved in formal curriculum or residency training. This is an interesting data point that I found. My reference disappeared, but there was a reference for this. 50% of clerkship directors serve less than 6 years. So that's important to know. Make it known. If you're interested in being a clerkship director, make that known, because chances are at some point in the next few years, there's going to be an opening either for a clerkship or an associate clerkship director. And like I said earlier, if they know, they're more likely to consider you. Ask about education committees. Most people don't like being on committees. I'm one of the weird people. I actually like committees, but most people hate committees. So if you tell your chair, I really like committees, especially education committees, they're going to file that away. And the next time somebody asks them to bring somebody into a committee, they're going to say, oh yeah, that person asked me, right? Instead of dragging somebody into a committee who doesn't want to be there. Okay. And then volunteer. If you see your chair is struggling with doing something in the education domain, just send them an email and say, hey, I see that, we're having a hard time getting around speakers. I'm happy to help with that. Chances are they're going to say, great. And if they don't, nothing was lost. So of course there's teaching, of course there's curriculum development, but I want to get a little bit more detailed in other aspects of education you can get involved in, right? Don't forget, advising and mentoring trainees and students is also a critically important role for a clinician educator. And in fact, some people do this extremely well and maybe do it better than they actually teach. And that's okay. Everybody has their role, and people have different strengths to bring. But ultimately, this is a critically important role. Okay. Every medical school has a formal advising structure. That's another LCME requirement, right, for students for their specialties. And so if you are in your field and you're interested in working with students, but you don't necessarily have time to run a course, you're not interested in running a course, but you love working with students and you love mentoring, well, then you can email your dean's office and say, hey, I'm a gastroenterologist, or I'm a pathologist, or I'm a neurologist. I'm interested in helping students applying into my field. Okay. Advising them for residency. Most likely they'll put you on a list, and next year you'll get 2 students, right? And you're going to help them, work through that process. Some people are really good at developing assessment methods, OSCEs, writing multiple choice questions, whatever it may be. And then, of course, I talked already about education leadership and administrative roles. And the other thing to remember is that teaching spans the continuum, right? So we think a lot about UME, at least I do, because I'm a UME person. But there's GME, and then there's also CME. Okay, I've heard people tell me this, that there's different types of educators. There's some people who love teaching students, some people who really don't, but they might like teaching residents. Okay, and some people really don't like working with trainees at all, but they like teaching their peers or colleagues or people in other departments about the important areas of their specialty. The good news is there's something for everybody, right? There's something for everybody, and that's really important. Okay. So let's talk a little bit about promotions. Okay, as I said earlier, it's important to meet with your chair annually to discuss your progress towards promotion. It's also important to know what the tracks are. Okay, would you ever drive somewhere that you've never been to before and not look up the map in advance? That makes no sense. Yet there are people at every institution in this country, I can guarantee it, who are frustrated that they're not getting promoted, but they don't even know the criteria. Okay, they were given the criteria at some point along the way because you have to get them, right? But they're on a website somewhere, but they don't know the criteria, and then they're lost. And that's not surprising that they're lost. They don't know the criteria, and it's not like they should just expect somebody to throw it in their lap, right? Of course, theoretically, they're supposed to have seen it, but ultimately, it's important that if you're driving somewhere, you in advance put together the map, or at least get the navigation set up so you know where you're going. Okay? Most medical schools have clinician educator tracks, but it's important to read the handbook to see which track sounds most appropriate, because there are many different institutions and many different tracks at each institution, and some are modified and some are unmodified and some are tenured and some are not tenured. And, but you have to understand what the tracks are at your institution. Okay. That's really important. And then understand what assistance you'll need along the way to get there. Okay. You're not going to succeed, I don't think, in your career without appropriate mentorship. And we'll talk in a minute about the different types of mentorship, but it's very important to check in, not just with yourself in the mirror, but with somebody who can look more objectively at the work that you're doing and let you know if you're actually hitting the metrics that are required for promotion. Okay. Faculty development is important as well. Okay. And then, of course, you have education peers who you can check in with. So an ideal mentor is somebody who is objective. Your mother shouldn't be your mentor. Okay, you can get advice from your mother, but she shouldn't be your mentor because she's going to say everything you're doing is great. Okay, maybe not my mother, but most mothers. So you have to be, your mentor should be objective. Should be somebody who's familiar with your career goals, and preferably not a superior. Of course, my chair is a wonderful person. I really have a great relationship with my chair, and I do consider him a mentor in my career. But I also recognize that he can't be my only mentor, because ultimately, we have a symbiotic relationship, right? My success is his success is my success. It's a little different. You want somebody who can look at it from the outside, who doesn't really have skin in the game with your success, right? They're totally objective. That said, it doesn't mean you shouldn't get mentorship from your superior. Of course, you should. And in fact, I would argue that if you don't feel comfortable getting mentorship from the person you report to, that's a problem, but that shouldn't be your primary or your only mentor. I've had people say, "Oh, I have this mentor. He or she was a Nobel laureate, but they never answer my emails." Well, they're not your mentor, okay? Even if they agree to be your mentor, they should be excited to be your mentor. They should be happy to help you, and they should be a better listener than talker. Okay. If they're talking all the time and not listening, maybe they're coaching you, but they're not providing mentorship, right? You really want to make sure that they're hearing you out. And you can have a mentor at your own institution, but you should consider having a mentor. I have one of my most valued mentors is somebody at an outside institution who can really look in with a critical eye as to what I'm doing and how it's fitting in, right, to what that person perceives as what's happening in my institution. You can have a near peer mentor, somebody who's maybe at your level, And even a senior mentor. Senior mentor might be somebody who's retired, who has a lot of time and is interested in helping people grow their careers. Of course, faculty development is important. You want to ensure that you can think you're a great teacher and maybe you're getting a lot of teaching awards. Doesn't mean that you can't learn, right? Just like if you're really comfortable with your clinical skills, doesn't mean you're not going to CME. Of course you are. And if you're comfortable with your teaching skills, you're still going to benefit from going to talks and seminars and workshops, how to build a better PowerPoint, right? How to write better feedback for students, right? How to provide better remediation. Take advantage locally. Every medical school, again, I hate to say LCME again, but every medical school, it's an LCME requirement to have a faculty development program for teaching skills. So it's going to be there. Some places don't advertise it well. My place really advertises it terribly. You have to look for it. We're changing that, but they're there. You have to find them, take advantage. National meetings. Many of us go to national meetings. We may not go for education reasons. You may go to a national meeting because you're presenting a poster or a platform session on a clinical research subject you're involved in. That's great. But while you're there, if you're also a clerkship director or if you're also involved in education, go to the meeting website and find some of the meetups that are for educators and get some networking going. Okay. And perhaps there's talks on career development like this one, or perhaps there's talks on teaching skills development. And then, of course, for those of us who are serious in a different kind of way, there are a number of external courses. These are just two examples, but there's others as well where you can get more formal teaching skills development. This is something that I tell a lot of people because I find that people can sometimes get lost in their departments. Clinician educators may have more in common with clinician educators in other departments than colleagues in their own departments. Okay, this is important because in relatively small departments, like in the institution that I'm at, we have some departments that are huge, and then some departments that are smaller, maybe 30 people, 35 people. And in that department, there's one or two people who are interested in education, and they can feel kind of isolated, right? They go to their department meetings, their grand rounds, nobody's talking about education, doesn't seem valued. Sure, it's happening, but they may find more in common thematically with somebody in a different department who's doing a similar role in education, right? So it's important to break those walls down between departments. Find that if your medical college has an academy of educators, or ours is called a community of educators, right? And join that. Get on listservs, right? And join workshops, meet people in other departments. Okay, it's really important. And don't expect any of this to fall into your lap. You want to put yourself out there because that's what's going to benefit you. Okay. So in order to get promoted, you have to demonstrate your impact. Okay. So I often tell people, don't tell me what you did, show me the outcomes. I mean, tell me what you did too, but show me the outcomes. Okay. A long list of things that you did is not as meaningful as a shorter list of things that you accomplished. Okay. And document it. Okay. Document everything that you're asked to do that you successfully complete. Document even things that don't seem that important in the moment, right? You're asked to give a talk, like I was asked to give this talk today, right? I'm enjoying doing it. It's a nice thing to do, but I'm putting it as a little, I make sure to write it down somewhere because then it's something that I was asked to give, right? So it's a sign that somebody acknowledged that I might be somewhat knowledgeable in this area, right, outside of my own institution. And then dissemination is important as well. It's highly unlikely somebody's going to be an associate professor if they never had a publication and if they never had an abstract, right, presented at a meeting. However, it doesn't have to be to the same extent in the education space, maybe as it is in the research space, quote unquote, but there has to be some dissemination. There also has to be a national reputation. And how do you develop a national reputation? Well, you don't develop a national reputation by sitting in your office all year, right? You have to get around. You have to network with like-minded individuals. You have to share educational resources so people kind of get a sense of the things that you're doing. You can join consortium. You can join, almost every specialty-based society. Every specialty-based society has groups for people interested in education. It could be at the clerkship, the program level, or it could be more generic. Okay. Certainly, if you want to become a professor, a full professor, you're going to have a national reputation. A lot of places, an associate professor, they'll say a strong regional reputation is good enough. My institution, you have to have an international reputation to become a professor, which is even a higher bar. But it's important to at least have a national reputation. So we'll finish up on education research, which is the qualitative and quantitative study of hypothesis-driven observations or interventions on the acquisition of knowledge or training. This is at least how it's defined in my specialty. And so what can we do, right? I mean, a lot of people tell me, listen, I didn't go into being education because I want to be a researcher. Okay. But what I tell them is, look at this great new curriculum developed. Okay, I'll give you an example. All right. We had a few years ago a faculty member who was upset that our residents were doing so poorly on a certain domain in our in-service exam. And frankly, clinically, they were struggling in there. So we triangulated it, and it happened to be reading EEGs and treating patients with epilepsy. And so that person basically complained. And my response, because whenever somebody complains to me, my response is, don't give me a problem, give me a solution. And they said, well, I have this really great resource I'm working on, I'm using it with my fellows. Maybe I can adapt it for the residents. I said, great, let's adapt it. Okay, let's adapt it. He worked on it, he adapted it, and that could have been the end of it, right? But what I said is, if we're going to do this, right, we're going to develop, it's not worth doing if you don't know if it works. So if we're going to study an outcome measure, right, are the residents performing better on that part of the in-service exam, right? Well, then we have the beginnings of an actual study, right? And I think what I want to remind people is when you're a clinician educator, you can leverage what you're already doing as scholarship if you think about it in advance, right? You're already developing a curriculum to fill a gap. You already have data to suggest that there's a problem. So recollect the data to see if your intervention helped improve it, if that was a solution, right? And if you structure it correctly with an IRB, if it's necessary, right? Well, then you have at least a poster, right, at a meeting if it's something interesting. Okay, if it's something more meaningful, you might even have a paper. Okay, keep that in mind. Now, a lot of people say, well, I want to do education research, but nobody pays for it, and that's not so untrue, but it's not 100% true, right? You're not going to get a big R01, for education research, and that's just a reality. Okay, you're probably not even going to get any real NIH funding. There's some exceptions to that, but there are, research grants. Here's an example of one at our specialty society, but many specialty societies have research grants. There's also, other grants out there. But I'm going to make an argument now that might sound, I don't know, problematic, but I don't think it is. So I'm a full professor, right? And I'm not here to brag. I'm a full professor at an Ivy League medical school. I've never in my career once received an education research grant. Okay, I was a co-PI on one that somebody else did for like $800 or something, but I've never received an education research grant, and I'm a full professor, right? So the reason I'm saying that is because you don't need funding. I've done a lot of education research and published, but that's because I'm leveraging the fact that if I'm doing something in curriculum development, the institution is going to pay for it, right? Who's paying for the standardized patient? The institution, because it's a curricular initiative, right? So ultimately, the work is being done anyway, and it's typically part of the structure of what's already happening in the medical college or the residency program. So you don't typically need a lot of money to do these things. Now, I'm being a little bit silly because you do need money sometimes for things like for statistics, right, et cetera. I recognize that. So there you might want to look at, engaging your research core for things like that, but you don't necessarily need this to get work done. That said, if you can apply for one of these, and if your project is funded, it's really going to help you for three reasons. One, it's going to give you a little bit of funding. Two, it's going to hold you to actually the outcome, because when you're getting an external body funding something, they're going to ask you for reports along the way, so they're going to keep you honest. And three, it's really going to help you with promotion to get funding from an external body. Where to publish, right? It's important to try to publish your work. And there are annual thematic issues in some of the bigger journals. But then there's well-known medical education journals. Here's just four examples. There's others. I don't mean to pick out one over the other, but these are four that I've worked with over the years that have been valuable to me. And then it's important to document, to make sure you're having your education portfolio updated. If you're going off for promotion on an educator track, it's just as important as your CV. And like I said earlier, don't wait until you're ready for promotion, right? By now, almost every medical school, there's a few exceptions I know of, but there's almost every medical school uses an education portfolio as part of the promotion process. And many of you probably here have an educator portfolio, so you know what goes into it, but it's basically a list of activities. Some things that would be overlapping with your CV, the vast majority are things that are not going to be in your CV, right? Your CV is not going to list your curriculum you developed. It's not going to list your professional education development. It probably will list your educational awards, and it might list your teaching activities. It certainly will not list your philosophy of education. This was a survey done a number of years ago of asking chairs of promotion committees what they look for in the when they're assessing a faculty member for promotion on these tracks, clinician educator tracks. And number one was teaching skills, but look at number two. Look at education research, right? Now, this is a while ago, so it's probably changed a little bit, but not surprising. What they look for, number one, is, are you a good teacher? And number two, are you a good clinician? If you're not a clinician, it's going to be hard to get promoted as a clinician educator. Okay. It's important that you have good teaching skills and good clinical skills, and all of these things kind of round it out. I'm going to move. Actually, no, I'm almost done. So, what are the methods of evaluating success in education? Like teaching awards are helpful, but they're often a popularity contest, and in and of themselves are have some value. But you want to have other things as well. Okay, peer evaluations can be helpful. Evaluations from your learners. This is a very big deal, actually. And as a curriculum dean, it always frustrates me when somebody goes up for promotion and doesn't pull their evaluations from our system. They may have 30 to 50 medical students who have said great things about them, and it would really help them in their evaluation. I'm sorry, in their promotion, but they don't actually download it. It's important to look for those if it's there already. And then, of course, your education portfolio. So these are some take-home points. Teaching, curriculum development, administration, and education scholarship are the key responsibilities. Whoops. Teaching skills are the most important criteria for promotion. You want to make sure that you're being versatile without compromising your core values. You want to make sure you're communicating in a regular and bi-directional way with your chair or your division chief. You want to make sure you know your promotion criteria on day one and plan that proactively. You want to seek out mentors who are enthusiastic and excited to mentor you and are available to you. You want to make sure you're developing a reputation of excellence in clinical care and teaching locally, and also that you develop an educator portfolio. So that's actually the end. So thank you so much. Appreciate your attention. And I see that there might be a question from somebody without a microphone. So you're going to type it out. That's fine. Go ahead. In the meantime, if anybody else has any questions or comments.
While we're waiting for the question, Joe, I just wanted to thank you for being here and for all the sage advice. It looks like the question's coming through, so I'll ask you one after that.
No problem. Thank you, Lori. I see here. We are developing a curriculum for clinician educators. What are key topics? So is that a curriculum for like faculty development for clinician educators? I'm assuming that's what you're asking about. Yes. Okay. So I think that this is actually a very prescient question because we were literally doing this yesterday. I had a meeting with our associate dean for faculty development. I think there's 3 or 4 topics that would be critical. I think one would be if for clinician educators, bedside teaching. I think that's critically important. It's not the same as teaching in a classroom, and a lot of the work that clinician educators do in terms of teaching directly is at the bedside. And I think that there's a big lesion and gap there, right? Rounds are happening. Rounds are a fertile ground for teaching, but those skills have to be taught. The second would be giving feedback. That's critically important. Learning how to give feedback verbally and in writing. Both of those they're actually different skills. You can actually have a separate lecture or workshop on each of those. But how do you tell somebody they're doing a great job? And how do you tell somebody they're not doing such a great job in a way that you don't demoralize them, in a way that you uplift them, right? There are skills, and most people can learn those skills. Some people have them naturally, and some people don't. Then written feedback is important as well, because, and that's a great one for a workshop, because one of the things that you can do is you can show like videos or describe scenarios, and then have everybody take a pause and write down how they would actually give feedback to that person. Learning how to give feedback that is not generic, right? Great student, would love to have them as a resident. Doesn't help anybody, okay? And that's specific. So I would say bedside teaching feedback, and then another one I think would be remediation, right? How do you help a learner who is struggling improve their skills again in a way that uplifts them, doesn't kind of destroy them. So for me, those are the three big ones. There's others. There's obviously other topics as well, but that's where I would kind of start. You can do how to write a lecture, how to make a PowerPoint without putting people to sleep.
Well, and that milestones document that was posted, the link is a good one too.
Yeah.
So we're at the hour, so really want to thank you for doing the talk today, Joe, and everyone will have the recording uploaded to our YouTube channel in the next 24 hours. So thanks everyone again for attending today.
I appreciate it. Thank you. Thank you so much for inviting me. Nice seeing all of you.
Take care.